Thank you very much. And so we will now go on to the live case. We can see Dr. Gambhir very well. Dr. Gambhir, can you hear us?
Yeah, good morning.
Good morning to you.
Yeah, how are you?
Very good, and very good to see you
So how were the
on the
kebabs
screen.
last night?
Oh, very nice. They were
Okay.
truly enjoyable.
Okay. Now coming to the case, can you have the slide, please? Can you have the first slide, please?
So can I just tell you that we have Dr. Sridhar Kasturi with me, Dr. Badri Narayan, and then we have Banerjee, Pravir Agrawal, I don't see, no, Jayesh Prajapati,
Your
Sandeep
name is?
Baswaraj, and Anand Shukla, Prashant
Rupali.
Nair with us.
Yeah, Dr. Seth, I have with me Dr. Rupali, who is one of the most trusted lieutenants of Dr. Goyal. She is assisting me in this left vein bifurcation stenting. And we have a team of other people in the cath lab who are the regulars here. And then we have a Japanese friend who would be on the OCT. There's some hiccup in the OCT, but in the meantime, let me tell you about the clinical profile of the patient.
Yes.
This gentleman, can you have the slide, please? Yeah, this gentleman is about 65 years male. He is hypertensive. He is a tobacco chewer, non-diabetic. He had non-semi acute coronary syndrome on 26th of February 2019. And the ECG at that time showed ST elevation in AVR with global ST segment depression. He had class 2 angina. Since then, ECG was became normal, and now the ECG is normal. Echo shows at that time inferior and posterior hypokinesia with ejection fraction of 44%. And his angiogram, which was done very recently, showed that his LV ejection fraction is nearly 50% now. So can we have on the recorded angiogram, please? Yeah. So this is his angiogram. This angiogram was done when? This was done on 2nd of April. Okay. You can see here that there is a very high-grade distal left vein stenosis, which is more of eccentric in nature. Can you go on to the other views? Next view. This was a epicranial kind of a view, which does not show us very much more information, except that the LCX has got several branches, obtuse 1, 2, 3, 4, 5. There are 4 or 5 branches. And the last branch has got some mild to moderate kind of stenotic lesions. Go to the epicranial now. Next view. Next view. Yeah, this shows again the osteum of the LAD. And yeah. And now you keep on this view. There is a very significant left main, and also the disease extending into the osteum of the circumflex, which has got a very tight stenosis, which we will show you on the injection which you have taken just now. The LAD as such has got a very tight stenosis. It is got a little longish kind of a stenosis. We don't know whether it's calcified or not, but doesn't look to be calcified, at least on fluoroscopy. Can you go to the next one? Yeah, this shows the LAD, a moderate kind of stenosis at the osteum, and the LCX. You are not able to appreciate much about the LCX stenosis in this view. Next. And this is the right coronary artery, which has got an 85% stenosis in its proximal part, and then 100% occluded.
Yes,
The
we saw the collaterals from the left system.
yeah, RCA was having collaterals to the PD from the left system. Now, we'd like to show you the 2 shots that we've taken just now. Can you run the shots just now?
So angiographically, what you have is a 1-1-1 left main stenosis.
Yes, yes, Medina 111.
With no other stenosis in the left system.
Mild degree of stenosis in the obtuse marginal branches, but may not require
Correct.
treatment
and
right
a
now.
right coronary artery occluded.
Yeah. So the just shows the first shot that we have taken here. The first shot, please. Go back.
I know that we're going to be short of time with the number of cases,
Yeah.
but it would still be.
Now this is the first shot that we have taken here,
Yeah.
which again doesn't show much. It's not a very nice view. Next, but the aleocaudal which we have taken. Next view. We'll go fast, please. Aleocaudal. Now this appreciates Show us the alveocaudal. Yeah. Next. Yeah. The alveocaudal shows a very tight stenosis at the origin of the circumflex with little, softness of the plaque possibly at the origin of the circumflex.
So
LAD
before,
is, just 1 second.
Yes.
LAD is not separated. Show the next one.
so
sure.
before you tell us what you're going to do, I think I would like my colleagues to
LAD,
comment
now
on
you
what
can
they
see.
would like
Now
to
you
do.
can see the LAD.
Yes, we see that very clearly.
Very
So, Dr.
clearly.
Sridhar,
Yeah.
we have the RC occluded, we got this left vein here. So what are your thoughts
I'll
around
take
this?
it out.
This case actually distal left main bifurcation, Medina 111, and even LAD lesion, not only ostium, the block is extending up to the distal LAD. And there is a distal LCS, mild to moderate lesion is there. So when this kind of LMCA distal, first of all, I'll see whether patient belongs to diabetes or not. If the diabetic is there, first option bypass. If it's unbelievable,
He is not diabetic.
none. The another one is this patient with the, I always calculate this entire score less than 22 or 2232, and based upon that, okay, now we have decided to go with the stenting. This is a classic case for two-stent technique. So two-stent technique, as per the recent ESC guidelines 2018, the most preferred technique is, because the data is more supportive, DK crush. But one should be, whoever is, suppose when you are choosing
Before that,
technique-
what do you think of revascularizing the RCA first? What's his ejection fraction, by the way?
So right coronary, I feel it's
This is the
not that
problem when
big.
you open this.
So right now, because the total occlusion is there, the L6 is really big compared to that one. I think straight away we can go with the two-stent technique of the left main. And but that time you have to have some circulatory support in the cath lab should be available when we are doing this type. When the right coronary backup is not there. So image guided left main bifurcation, two-stent technique. My choice is preferred is DK crush.
So anybody in the panel would want to open up the RCA prior to this left vein stenting first? And the second question is Gambhir, what was the ejection fraction of the patient?
If we have done a LV angiogram only a few days ago, it shows nearly 50% with some
It's a normal
hypokinesia.
ejection fraction.
Nearly normal LV ejection
And so
fraction.
can I just ask would you want a hemodynamic support? I'm just asking the panel.
That is my worry. If the triple vessel, almost like triple vessel with left main disease, why not with hemodynamic support we will proceed the case?
Neighbor.
So anybody in the panel feels differently than what Dr. Kasturi said about firstly just going for the left main, not bothering about the RCA first, and the second issue is hemodynamic support.
Now why are they doing this?
People
Let
are
me
very
put the
worried
wire
about
again
doing
here.
left veins without
Which is
hemodynamic
which is
support.
very-
Hemodynamic support should be available.
Go to
but
RO
no need to give many steps,
RO-caudal.
we can.
So I think it's a fair, I was
Can you
just going
reduce
to
the
ask the
volume?
panel if anybody had
Can you
any
reduce the volume here?
different feelings around this.
So if the vital is stable, then we can
No,
keep
no,
the
no,
stent
do my profile.
upfront because the resting LV is normal.
Right.
If the operator is experienced enough to get the thing done as per his plan, if anything goes against his plan, then
This is the-
immediately available hemodynamic support is
RO-caudal.
Fair enough. So I think the consensus is, and it's appropriate, a consensus is that hemodynamic support for this patient with a normal ejection fraction is unnecessary. But if this guy had systolic pressures of 100, ejection fraction of 25%, and his PAs were up to 60, I would actually put him on a hemodynamic support.
even LVDP can be measured before the start of procedure.
Oh yeah, you can measure PA pressures rather than an EDP, and that's good enough to monitor the patient in an impaired LV function. It's a mandatory requirement
Test.
to monitor a patient with impaired LV function during high-risk PCIs.
Test.
Please. Go ahead on the panel.
Large right coronary. The right one is co-dominant. And if this is a large right coronary, I would have revascularized RCA first.
Test.
Because if you block the left main with the balloon, then you will have a significant hemodynamic compromise. If this was a dominant right coronary, I would have done the right first.
Again, if it was impaired LV, you would have actually wanted more support from the RCA.
RCA.
Now, one of the things we must realize is that if you got a critical 90% left main, I'm not in favor of wasting my time on revascularizing a total occlusion with large amount of prolonged procedure and dye in the face of a 90% LAD to be revascularized. I'd rather get on with the job and save the patient as efficiently as possible. So I'm okay with what Kasturi said. Go ahead, do this critical left
No.
main LAD circumflex bifurcation
Now
without
give me the,
necessarily going for the RCA CTO with prolonged. Remember, you've got to give contralateral injections into a very tight left main. Unnecessary. Treat the left main first.
Dr. Seth,
Yeah.
a small point here.
Yeah, please go ahead.
I totally agree with you that, many times we forget that right coronary artery supplies only 10 to 15% of the heart muscle. And if suppose by chance there is any problem in the left main while doing the angioplasty of the left
There
main,
is an ostium of
Uh,
the LCX.
the right is not going to protect you. Please be sure the right is not going to protect you. So whether you open up the right first or later on doesn't make a difference to me. And as Said has put, I'll first put my bet on the left main and then look up at the right coronary, which may be openable, which may not be openable. So that's what my view is.
The moment you open this left main, his hemodynamics get better anyway. So I think you aim for the right buck.
So what we have done now is that while we're discussing, we have taken a
Yeah.
pullback of the OCT from the LAD to left main, and we are now putting the OCT into the LCX and take a pullback from LCX to
Okay.
left main and see what is the kind of plaques we have and whether we need to do any debulking or not.
So Dr. Gambhir, just to time pace you,
Yeah.
we will be with you for 8 minutes now
Okay,
before we
okay.
shift on.
Okay, okay,
And
okay.
So you may want to show us the right things now
Okay.
and then later again.
Okay, okay.
Sir, my comment on LCX imaging to decide whether LCX stenting is required, because there is a CANG series, they have shown very clearly.
Okay.
Angiographic stenosis, it may look small, but the functional stenosis is less. They studied 42 patients. When they analyzed 42% of the
Ready?
patients angiographic.
इसका volume कम कराओ.
More than 50% region, they showed 42% angiographically, more than 50%.
Okay, start.
But when they did the FFR,
Okay.
it was positive in
That's
only 8% of the patients. So that's the reason when you do this, preferable to go with provisional. And if you
Bit drop it,
decided that two stents, let's say
What
it's
is- what are
really
the-
tight,
Okay.
then
I-
decide and do the FFR.
Is there
If the
calcium in
side
the-
branch is very
No,
significant.
no, I don't think so.
Two techniques.
So we just do a
Not
balloon.
so
That
much,
DK
not
crush.
so much
And
calcium.
after the
Okay.
provisional
We only do a
stenting
balloon
also,
dilatation.
check the again.
Yes, the
Suppose if you are doing
dilatation is
provisional
enough.
stenting, do the side
I
branch,
don't need- I
FFR.
think we
If
don't
that
need
is
a lot of
positive, go with the
Okay.
T-tap. That would be
Fine,
the
fine. And circumflex?
So
This is a
here if you're
circumflex.
doing, again, another
here
point of
is
doing
an-
FFRs,
There is
is that if
small
you really were doing
calcification,
FFRs,
So
then the
you give the
LAD would have to
commentary
be
of the,
revascularized before you
yes.
actually got a
the
good
OCT. Let me
accurate
start putting
FFR on
balloons.
the circumflex.
Okay. Give me balloons, 2 millimeter.
A closed LAD would actually create increased
Don't take
perfusion
out the wire.
down the circumflex system.
Be very careful because whisper wire is notorious.
What about the imaging in
So would you tell us, Dr.
I've
Gambhir, that
seen.
you-
Yeah.
your strategy up
Pardon?
front is what do you intend doing?
Now, since this is a distal left main Medina 111, we have done the OCT and the findings will be very soon shown to you. But what I'm told is that the OCT does not show much of calcification in either of the two vessels. The LED left main, there's small calcification in the circumflex. So therefore, there is no real need to prepare the ground for stenting in this patient. There is no need to modify any of the vessels by any of the modifying techniques like rota or cutting balloon, etc. So we'll simply go with a balloon, and what we plan to do is a tap technique here. So is a short ostium of the circumflex short lesion. So we'll put one stent from the LAD, and the exact length and the diameter of the stent will soon let you know on the OCT. We'll put the stent from the proximal part of the LAD backwards into the left main, and then take a second stent and do a tap here. I think that would be a very simple, easy, and not time-consuming technique.
So you are in favor of a tap
Yes.
rather than
DK crush.
So I would just tell the panel, tell the audience out here, forget the studies. In left main, do what you're comfortable and good with. The studies have actually been
Give me
done
balloon.
in multiple ways. And while we may actually say DK crush is good, but remember those operators who did DK crush had been doing DK crush all the time, but it never actually said that any other technique would be non-inferior to DK crush if done by experts who always do that technique. And by the way, this is a great case for TAP anyway, because firstly, it gives you the possibility of provisional rather than two-stent strategy. And secondly, that it's at a right angle, and it's just ostial, and you can place a small stent at any time later on. So I'm absolutely in favor of what Dr. Gambhir's. Actually, it's a great teaching
Right.
point in this situation.
Right, Ashok, I again agree with you that, you see, of course, there is a data to show that DK crush in left main is better than the culotte. It has not been compared to any other technique, but with the culotte, yes, certainly. Maze rate and TLR are lower. But then here, if you see at the angle, it is almost 90-degree angle. It should be a good case for any of the T or TAP techniques, and you really do not need a DK crush.
Yeah.
The second part is that obviously DK crush has more steps,
This is the
and
this is the
you know the time constraint here, so I have to finish the case. So I have to do a good case within the time frame, and I think TAP should be a right answer.
Yeah, and it's always it's always a provisional, helps you with a provisional strategy if you thought it was a provisional strategy.
Can we have the OCT image? Yeah.
So
We are going to just show you the OCT. Just wait for a second. We are going a balloon dilatation here.
Yeah, let's not disturb Dr. Gambhir in what he's doing, because it's left main, and he's also got a time constraint.
What about the
If he has time, we will come up with those
Hold this
images.
fire, hold this fire.
what about the imaging in such kind of lap main, OCT versus IVUS? With suppose patient got LV dysfunction, whether you go for OCT or IVUS in such case?
Give me the other balloon.
So-
Hello,
back in.
can you hear
So-
me?
Personally, I think we can answer it on the podium rather than Dr. Gambhir dwelling on this. He should concentrate on what he's doing. And here's the answer to you. OCT provides great images, and irrespective of LV dysfunction, you can still limit the amount of contrast which is used. However, one thing you have to remember, that the outcomes of measurements, optimization of left main, outcomes have been only linked to IVUS findings
Push it.
and not yet to
Push it like
OCT
this.
findings. And we're talking about long-term outcomes based on final optimization. You cannot, because they actually work differently and take images differently, there's no way you can extrapolate the measurements of IVUS to the measurements of OCT till proven otherwise in any longer-term study.
No, one more
And
point,
therefore-
Ashok. Sorry.
Yeah,
Sorry,
go ahead.
carry on.
So,
No,
Gambhir-
one more point which I like to say is that the advantage of OCT in any vessel, whether it's left main or otherwise, when the lesion is calcified, you can see the depth of the calcium. You can measure the extent of the calcium. You can measure the thickness of the calcium, which possibly is not very nicely measured because you can't see in IVUS beyond the calcium. Whereas in OCT, you can see the posterior to the calcium, and you can measure the exact thickness. So that helps you to decide about the strategy of a debulking. Okay?
Hello?
Yeah.
So I would say OCT
this
may be a
is
shade
Uemura.
better.
So in optimization, I always
go on.
use IVUS. Even if I've used OCT, I would use IVUS at the end to be sure that it's optimized in a complex left main bifurcation,
Done.
not in a routine lesion.
Okay.
Now, Gambhir,
Yeah.
we're going to be moving to the other lab.
Okay, please.
What you've done is, I think, dilated both
Yeah.
the vessels.
Yeah, we have
Hello?
dilated both the vessels, and in the meantime, we are preparing for the stents now, and then you can go on to the other lab.
Yes, could you keep recording every step so that
Yeah,
when
yeah,
we
yeah,
come
sure.
back, you can take us through
Sure,
this?
sure.
So now we can shift over to the other lab. Dr. Gambhir, we are
Yeah.
with you.
Yeah. So let me just, we have already deployed a stent in the LAD to left main and did a OCT even after deploying the stent, and then did a pot in the left main and again did a OCT. We are now trying to get into the circumflex.
Ah, okay. Oh, yes. Hello,
Give me a test.
this is Uemura. Let me introduce the OCT findings. So, can you put the OCT on the screen?
Test.
We are unable to see OCT.
You can,
Sure.
okay, that's fine, okay. So this is a pullback from LAD to LMT. And here is a distal LAD.
Give me 1
Okay,
millimeter balloon.
can you see?
2 millimeter balloon or 1
Here we
millimeter.
can see the septal branch is entering
This is the
into
value to
here. And we can see the stable fibrous plug. And here we can see the
Now give me
ostium
quickly a
of the
small balloon.
diagonal branch.
To direct.
And I think this is a good position for distal stent landing. The mean diameter is about 3.0 millimeter. So we recommended to use the quarter upsize stent 3.25 for these regions. And this is a proximal part. We can see the significant stenosis in the proximal LAD, and we can see the lot of lipid accumulation from 11 to 4 o'clock. And this is the tightest region. And we can see the cholesterol crystal
Leave the
at 1 o'clock, suggesting the very large lipid pool. And at 8 o'clock,
Yeah.
here is an ostium of the LCX. LCX ostium is very tight stenotic. And here is the distal LMT. We also see the significant lipid accumulation.
Give me 2 millimeter balloon now.
And here we can see the rupture,
Quickly 2 millimeter
silent rupture site in the distal
You hold the wire.
LMT. So we need to cover this position.
balloon. Hold this
And
one.
here is the proximal landing point. Mean diameter is almost 4 millimeter. So
Give me
we
212.
recommended Dr. Gambier to use 3.25 diameter, and the stent length is 16.
So,
this-
so did you see a thin cap atheroma just there? I just saw that as a flash by.
Just a moment. And
I saw
so
it in the
fibrous
left
fibrous
Here,
is
here
not
is
so
backwards.
thin.
Backwards.
Mm.
Still, still you have to come back.
Here,
Still, yeah, there.
yeah, this is a ruptured plaque. This is not thin cap to fiber atom. I think previously ruptured site.
There.
Okay.
It's here,
Yeah.
maybe, but I think here I think this is a calcium deposition in the proximal part of the LMT. So,
13.
but
Once again.
this
Once
is
again.
circumflex.
Yeah.
Mm.
Cross the wire,
Yeah.
and now you're dilating the side branch.
Yeah.
Is that correct?
Yeah, yeah. We have just put a 2 balloon and open up the strut of the LM to LED stent towards the circumflex.
And that's the distal. Can you demonstrate? Did you record the fact that you crossed through a distal strut?
Oh, well.
Just a moment. So
he
let
will
me show you
us on the
the
OCT.
OCT finding
You-
just
we will
after
do a
stent
OCT right now.
implantation.
There's significant mala position.
But
Do you see the?
let me just take a shot here.
I know you'll get a good
Remove
result
that.
at the end, but this would be interesting for people, audience, to see if you can get a good OCT.
No, see,
shot.
Ashok, the point is that distal crossing is much more
Okay.
important in patients who are going into a mini crush kind of a technique. But when you're doing a tap technique, I think it is immaterial wherever you cross. There is no much difference whether you cross it from the proximal or distal. And many times it is not very easy to find it out also where you have crossed unless you do a OCT at the same time.
Dr. Gambhir, I think it becomes important in the tap to actually be as distal as possible and for crush to go through proximally. And especially in a right angle circumflex, it's so much easier to go through a distal strut because the ostia of the circumflex is usually
Yeah,
large.
but that we can see it only on the OCT now.
Yeah, so have a look.
Yeah,
Or you could have
we have
demonstrated
to
on
use
your
that
trapped
machine.
wire that if you were further ahead from your trapped wire, you would be through a distal strut.
okay. We are, you just take a, we have done a part, we have not done a OCT
yeah.
after that, no?
Okay.
So let's,
So
let's
let me
take a
explain.
OCT, again pull back and we'll show you all those things.
Sure, great.
LED to left main OCT.
So
there is significant malposition that is in the left main.
But we cannot
So
see
it
the
has to
3D
be,
nature.
a part has to be done because
No,
cross malposition.
we have done the pot. We have done the pot, and we are now going to show you the OCT, and then you comment, please.
Okay.
We have done the.
Dr. said it might be worth asking a comment from Professor Lugar because he was nodding his head when the comment was being made about the crossing.
Okay, yeah, sure.
In the
Professor
review.
Luar,
New record.
about the distal versus proximal crossing in this left main bifurcation, if when tap is contemplated versus when when a
We-
crash. has
Ready.
been performed.
We know from bench in the 90s that when we enter the
Post
side branch towards the most distal cell, we are projecting some metal just to cover the orange quarter at the ostium of the side branch. And this is the basis of T or tap technique. So, but we have the confirmation of that only with the work of our Japanese colleagues that are identifying the place we are crossing towards the side branch with 3D OCT reconstruction. I hope we'll see that. And if
So
he
you're
was
suggesting that
if he
it's a
was
distal
crossing
strike.
distally, yeah, we have to cross distally. If he was crossing distally, then the tap will be minimal. If he was crossing proximally, there is no metal in the side branch, so you have to protrude a bit. So this is, personally, I use something much less expensive
Okay,
than OCT,
that's fine.
which
Okay,
is
let's do again.
stent enhancement. In stent enhancements, you know, after doing it first, if you enter the distal cell or the proximal cell. So this is how we can adapt step by step the place of the stent.
So you create a lot longer carina if you actually more proximal.
Yeah, avoid accumulation of metal at the carina, because this is a critical point looking at the recent publication on René Vermani.
let's
When
see.
you have a lot of metal on the carina, there is a risk of stent
Sir, I
thrombosis.
need one clarification, sir. Sir, one clarification.
But,
So,
Dr.
they
Luar,
said, one clarification, sir, because many cross they say the proximal stent crossing, whereas remaining all other bifurcation stents distal crossing. Because mini crash,
Cannot
if
see.
you cross distally, more struts are at the proximal end. So that's the reason they say mini crash, the proximal
Let's take a
proximal
stent.
strut should be, remaining all
You're asking the
stents,
stent for that.
bifurcation should be crossed distally.
Yeah, many are crushed because otherwise you expose the vessel.
No,
What
so
side
I
is
cannot
what side of
see
the
guide
stent in
wire
the
where.
circumflex?
Okay, so where are we now?
So, Ashok,
Yeah.
we have done the pot,
No, not
and
so
we
good
have
image.
also taken a pullback, OCT pullback, and
Let's
he-
see. This
yeah,
would be
okay.
interesting, Dr. Ida.
Yeah.
So it would be
Dr. Oman.
interesting to see.
you show us the OCT pullback now.
OCT.
Okay,
He's just loading it.
so let me show
and in the
you
meantime, I'll
the
take a stent
OCT
and
image
take it
just
down into
after the
circumflex.
implantation
Okay.
of the stent. So this is the stent image. Just a moment,
It's
please.
a very short stent. 3 into.
So you can see this is a 3.25 stent implanted with nominal pressure. The distal apposition is very good, but if you look at the stent in the left main, you can see the significant malapposition like this. Here is an just a moment. Malapposition. Oh, yeah,
Give me
like
a
this.
312 Zines.
As you can see, the malapposition distance is almost 0.8 millimeter
Right.
at like this. So we have to do pot first
Yeah.
to oppose the stent strut to the vascular wall. And Professor Gambier performed 4.0 millimeter pot procedure. And this is the OCT after the pot
give me a
procedure
balloon,
as well as the
Give me
recrossing guide
3.5
wire.
millimeter balloon. 3.5
Unfortunately, the blood, yeah,
Or in
the
fact, 4
removal
millimeter balloon,
of the
same 4
blood is
millimeter
not so
balloon,
good,
4 balloon.
but you can see the very good distal apposition like this, and blood, residual blood here.
Can you show us where the wire is?
Yeah, this
Into the
is
side
a
branch.
main branch guide wire, and this is side branch guide wire, but we cannot trace the guide wire because of the residual blood.
That's right.
Unfortunately, we cannot assess
Can
the
you go into a
position.
reconstruction?
So this is the older type of OCT.
Okay.
Sorry.
So,
but-
Dr. Gambhir, can I
Yeah.
just tell you that you have 2 minutes to go. If you show us your tap and then
Yeah,
what
we
you're
are-
doing in 2 minutes, then we would be having a final angiogram, and then you can optimize it later. If we
Okay.
go to Viveka
Okay.
for the last 6-7 minutes.
Okay, we are now getting a balloon down into the LED, and then now a stent is going into the circumflex. We have taken a 312 Abbott stent, Zions,
Right?
and this is across the stenosis. And now we have
Because the stent is on the marker,
Yeah.
you're able to actually deploy it
Yeah.
accurately.
to accurately,
in a
don't worry.
tap.
Yeah, so give me a little short test.
Yeah, I prefer these stents for doing these bifurcations for this reason.
Can you bring it this side? I'll have to pull it bit.
Mm.
Okay,
Test. I think I'll have to pull it further on.
the important thing to understand is that you've got to
Yes.
imagine not the ostia, but also imagine
Yeah,
how
I
it
think
is
I'm
when
right.
the stent opens.
I'm perfectly okay now. Go ahead with the stent. Go ahead with the stent.
And it's always a good idea to check it up in 2 views. Dr. Gambhir
spider
got
will
less
be
time today.
Yeah, you can take a LA caudal.
Okay, spider view.
Yeah,
Mm.
give a test.
Because this could show you much better.
Yeah,
And it's deep, it could be deeper in.
yeah, that's okay.
Mm. That's
Okay.
okay.
Yeah, go ahead. I wanted a little about 1 to 2 millimeter protruding into the left main, so that we don't miss the ostium. Down. Okay, go back onto the AP caudal. Okay.
So how about
Now what I do normally is that I pull back and give another inflation here. Give another inflation here. Yeah. Send balloon
Can you change the machine to
down.
Right, and here you went up to high pressures.
No, we have as yet not put in a non-NC balloon. We have went up to about 12 atmosphere.
Okay.
So we pull out this and
And is
with
this a non-compliant balloon in the LED?
we have a non-compliant balloon in the LED. Yes, that's right.
Okay.
So there are 2 ways of now doing it. We either take out this wire and recross it, which I don't like. So we will put a non-compliant balloon straight away into this wire, and then do a hold it, and then do a kissing balloon. Give me a 3O NC balloon. 3O NC balloon. And in the meantime, we'll take a shot here. Give
Okay, you
me
can take a shot, and I know that we will then complete the procedure appropriately.
shoot.
Oh, fine.
That looks fairly okay, but we just have to do a non-compliant balloon here.
Yeah.
NC balloon 3 into 12.
And you'll probably certainly have to work and look at the OCT because the ostia of the LED certainly needs
Yeah,
more
yeah,
work to be done.
yeah. It looks so on the angiogram,
That's
but at least the stent apposition is very good in the LED ostium also, because LED ostium is not very big. But we will take a OCT at the final, and if the need be, we can go to a 3.5 millimeter balloon.
Great.
So we are just going to give a final kissing balloon here in the.
Okay, so Dr. Gambhir, you do that, and we're going to actually go to Dr. Viveka
Okay.
Kumar to
So-
see what he's doing in the last 5 minutes.
Okay,
And thank you very much for a great demonstration of a
Okay.
case,
okay,
which is
go ahead,
wonderful.
go ahead.
Just want you to all understand that this kissing should be in the polygon of influence rather than bring up to the ostia of the left main. So polygon of influence is where you keep the balloons when you do this kissing.